all of you, and often you, Dr. Gareth. This is an international speaker program initiative by PHO, IAP PHO, and this initiative strives to bring in new and emergent topics for discussion. So these are some of those topics which are increasingly being discussed in forums, and something which are not, which we are being increasingly exposed to, but we don't have that much exposure in that sense. So these are those Zara Hatke topics, and we actually welcome you to this session. So Dr. Gareth Wheel is the professor of cancer pharmacology in Newcastle University Center for Cancer, and he's a lead in a lot of PK and pharmacogenomic studies, and has mentored several PhD students. And yeah, of course, several honors and publications in his name. So he'll be giving his insightful thoughts on a very unique topic today, utilizing clinical pharmacology studies to support the treatment of childhood cancer patients. So without much ado, over to you, Dr. Gareth.
Thank you very much. Can everybody hear okay? Yeah.
Yeah.
Yes, your audio is clear. Yes.
Great. I will just see if I can share my screen. Can everyone see that okay?
Yes, we can see this.
Okay, great. So what I will try to do in the next 45 minutes is give an idea or a flavour of how we're implementing an increased knowledge of the clinical pharmacology of drugs used to treat childhood cancer patients to support what can often be kind of difficult treatment decisions that need to be made for many of these patients. Just like to mention the very start rather than at the end, the range of different charities and groups that fund our work here in the UK and across Europe. Okay, so the reason why we really focus on clinical pharmacology in childhood cancer is because we're a million miles away from having anything that could be described as a perfect drug. We deal with real drugs where we need to think about different doses for different patients. Obviously, a 2-day-old child is going to need a very different dose than a 16-year-old child. We see responses in some patients. Sometimes we can understand that through biology, sometimes through pharmacology. And also, different patients have different levels of adverse effects. And some patients are not able to tolerate chemotherapy very well, whereas others can sail through their chemotherapy courses. So it's really trying to introduce the idea that by understanding clinical pharmacology and differences in drug exposure between patients, we can actually make a difference in terms of how we treat children with cancer. So, you know, in the modern world of personalized treatment and precision medicine, we always say that, you know, you need to get the right drug for the right patient, but we take that step further and say it's getting the right dose of the right drug for the right patient. This is a figure from a review paper published a few years ago now, but it really just highlighted the fact that a lot of the advances we've made in treating children with cancer, and this is an example with acute lymphoblastic leukemia, which is often given as the kind of almost like the poster boy of how advances in chemotherapy have improved the way we treat children with cancer. So, you know, going back probably sort of 50 years, if you were diagnosed with acute lymphoblastic leukemia, you wouldn't survive your treatment, whereas now we have up to around 80% long-term survival in patients. And actually, when you think about it, there aren't that many new drugs. So most of the drugs that we use in acute lymphoblastic leukemia are the drugs that have been around for many, many years. And we've become better at understanding what is the best way to use those drugs in terms of combination chemotherapy and in terms of understanding the importance of dose intensity in those patients. A massive problem that we now face is the fact that we have around, so this is European statistics. I should have changed this to global statistics, but this slide was put together for a European conference. So in Europe, we have over 500,000 childhood cancer survivors, and it's estimated that around 2/3 of those patients who've survived their treatment experience long-term health issues and poor quality of life, which is directly related to the treatment that they have received. Cumulative dose of anti-cancer drugs is associated with an increased risk of many late effects, where that's kind of clearly been shown. So really, there is a clear benefit in potentially kind of understanding the relationships between drug exposure and toxicity alongside a response. So I've got a few slides here. This may be kind of a bit too simple, but a few slides just on the basics of pharmacology, just to make sure everyone's got that kind of basic knowledge to be able to understand the work that I'm going to present. So pharmacology can be split very simply into pharmacokinetics and pharmacodynamics. The definition of pharmacology is really how the study of how drugs affect a biological system. And when we think about pharmacokinetics and pharmacodynamics, the simplest definition is basically, with pharmacokinetics, is what the body does to the drug. So any drug is seen as an exogenous substance. It wants to get rid of it. So how does it break it down? How does it metabolize it? How does the body clear it? And then pharmacodynamics is essentially anything the drug does to the body. So that could be a measure of response. It could be a measure of toxicity. If you're targeting a particular enzymic pathway, for example, in a cancer, then it may be a marker of kind of how much you're knocking down that particular target. So very simple, if we take a drug which is orally administered, the drug is taken, a certain percentage of that drug is absorbed into the systemic circulation, into the bloodstream, and then it will distribute around the body. It will go to different tissues. And at the same time, there will be an elimination process where the drug is cleared, it's metabolized by the liver and cleared by the kidneys. And obviously, these are complex interactions. And what we're trying to do in terms of clinical pharmacology is really understand those kind of complexities, those subtleties between where the drug goes, how widely it distributes around the body, and how long it stays in the blood for, and what are the potential relationships between the duration of exposure or any of those PK parameters and the kind of clinical response and toxicity that's seen in a patient. So the things that we commonly measure in clinical pharmacology studies on the clinical side, so we run clinical pharmacology studies, we'll obviously take blood samples from patients. And we will do this at hospitals around the UK or at centres in Europe. On the clinical side, we will want, as well as basic information on things like drug dosing, drug timing of drug dosing, we will want the information on what toxicity is observed in patients and whether there's a readout of efficacy, any efficacy data. And then in the laboratory, we will look at pharmacokinetics. So we will look at which patients have a high exposure or a low exposure, pharmacodynamic endpoints, as mentioned, and also maybe pharmacogenetics or pharmacogenomics. And I'm not really touching on pharmacogenetics within this talk. I could you could do a whole seminar on pharmacogenomics and potential impact of genetic variation in patients and how that can impact on response and toxicity. And part of that will be through differences in exposures of drugs. And this graph on the right-hand side here is this very simple curve of drug concentration versus time. So simply showing at time following drug administration, what are the actual concentrations of a drug? And we will measure those levels in blood samples, and we can determine essentially, which I'll go on to, what is the exposure, essentially the area under this curve of drug concentration versus time. The reason why this is particularly important in a pediatric oncology space is because we don't have the luxury of having large differences between the kinds of concentrations that cause response in patients and the kinds of concentrations that lead to potentially quite severe toxicity. So in an ideal world, you want to be giving drugs where this dose response curve for your therapeutic effect is a long way away from your kind of toxicity response curve, but in reality, for a lot of the well-established cytotoxic drugs we use in children's cancer, they are very close or even overlapping. So really, it's very important that we understand exposure and try to avoid those kind of concentrations that are going to cause more severe toxicity in patients. And this is just a kind of cartoon, a very simple example of what we may see with 3 patients. So there are thinking about pharmacology, there are 2 things which, depending on the drug and the mechanism of action, there are 2 things which we're interested in. One is essentially the minimum effective concentration that's achieved. And this has been shown with drugs like methotrexate, where unless you're achieving a particular minimum effective concentration, you're not going to see the benefits of the drugs. And then the second thing is measuring the actual overall exposure, which is the case for the majority of drugs and is a more useful parameter. So in this case, the overall drug exposure is essentially, if you mathematically calculate the area under each of these curves. So this patient here in green has clearly got a lower exposure. They're only above this minimum effective concentration for a short period of time. And the area under this curve is much lower than the patient in blue. And again, that's lower than the patient in orange. So looking at this very simplistically, you could say that the patient in green is being underexposed. So they would benefit from a higher dose because they're not really within this kind of between the blue and red lines is what we class as the therapeutic window. It's the kind of target exposure. The patient in orange is going way above this kind of red line, which determines where you see more severe toxicity. So this patient could potentially benefit from a lower dose. And this patient in the middle is kind of where you want to be. The patient in blue is within the kind of therapeutic window for a good period of time, but the drug exposures, the drug concentrations that we measure are never actually achieving concentrations above that toxicity threshold. And that's a very simple mathematical way that we essentially measure the area under the curve. And we will have nice software packages that do this for us. But essentially, it's a mathematical relationship between breaking this down into sections and measuring the area under the curve, measuring the area under each of these trapezoids, which gives you the total area under the curve. And AUC is essentially drug exposure in these patients. And this can have quite a big difference. Again, this is just like a nice cartoon saying that the same dose of drug can be given to two patients. You could have a twofold difference in clearance. This may be a clearance of 50 milliliters per minute as compared to 100 milliliters per minute. Quite common that we do see variation in clearance levels between patients. So 2 or 3-fold is very common for the majority of drugs. But the difference that can make is the patient that has the lower clearance will have the higher exposure of the drug because they're getting rid of the drug more slowly, and therefore they're more likely to see an effect. Whereas the patient with the faster clearance, the patient that clears the drug from the body much more quickly, has a much lower exposure, and therefore they may not see or less likely to see any effect of the drug. So understanding pharmacology, understanding exposure is going to be important for these patients. So here in Newcastle in the UK, we spend a lot of time developing novel assays to allow us to measure drug levels in patient samples, in clinical samples. There are obviously lots of regulations around this based on sort of the rules of developing what we call a fit-for-purpose assay according to the European Medicines Agency or the FDA in the States. So we spend a lot of time making sure that we develop our assays according to these kind of regulatory stipulations. And we now have assays for close to 50 different drugs. So a lot of those will be newer drugs that are coming through, but also a lot of well-established drugs that we use in pediatric oncology for measuring patient drug levels. So what's involved in running clinical pharmacology studies? So the drug will be administered to the patient either orally or intravenously or by another route of administration. We will commonly collect the most common thing that we measure drug levels in is plasma as a nice clean matrix, but we may sometimes look at collecting whole blood samples. We may be interested in drug levels in, for example, white blood cells. We can isolate peripheral blood mononuclear cells from that whole blood sample. Sometimes if we're interested in only free drug levels, like for the platinum drugs, we will actually spin down the plasma to obtain the ultrafiltrate, which is essentially the non-protein bound drug. And then we have a whole range of different ways of detecting drug levels, whether that's from a pharmacokinetic or a pharmacodynamics perspective. But most commonly now, liquid chromatography mass spectrometry is used for measuring the vast majority of these drugs. And then we will get raw data from the, for example, from the LCMS machines. This will all be data is verified and QA approved. Again, quite strict regulations in terms of how you handle patient samples. And then this is what my desk will look like quite a lot of the time where I'm analyzing data and doing pharmacokinetic analysis on that data. Again, those final outputs are quality assurance approved, and then reports are written, and that's either fed back to clinicians or to industry or to, for example, Cancer Research UK, we do a lot of clinical trials with. So I was going to touch on early phase trials. We do early phase trials, and for obvious reasons, the majority of these are in adult patients, but this is very much looking at the safety profiles of new drugs when they have completed all of their the preliminary data has been collected, and they have a license and ethical approval for going into first-in-man studies. So we will develop assays to allow us to quantify those drug levels once the patient goes into man for the first time. The primary focus of this is going to be safety, but the secondary focus is always on understanding the drug exposure, and that can impact now on obviously how we administer a drug, how frequently administer a drug, for example. We have kind of increasingly novel clinical trial designs for early phase studies to try to kind of like, while we concentrate on safety, we will do, for example, one patient cohorts for the first few cohorts to just kind of speed up that process as long as that is shown to be safe. We develop novel PK and PD assays. These studies will have commonly phase 1 trial in an ideal world will be probably between 30 or 20 and 50 patients and will be completed in a year. In reality, because of kind of like competition for patients and numbers of patients recruited, they can take longer than this period of time. And these will always be run as either national or international studies rather than being run at a single site. It's possible phase 1 studies may be done at very large single sites, for example, in the US, but rarely here in the UK. So in terms of analyzing pharmacokinetic data and pharmacodynamic data, what do we use this for? How can this be used to benefit patients? So I've said that in those early stages of drug development, in the early phase trials, the pharmacokinetic data can be used to inform decisions on kind of like dosing schedules and dosing rates of administration. Do we dose once daily, twice daily, once weekly? And that will be determined partly by the pharmacokinetic profile of the drug. We know that there are good correlations between the drug exposure, the AUC, and the drug. So it's obviously a useful parameter to be measuring. I'm going to go on to talk about some therapeutic drug monitoring work that we've been doing here in the UK for the last few years, where the pediatric kind of clinical healthcare workers and clinicians have really bought into this idea of using clinical pharmacology data to improve the way we dose patients. And increasingly now, we're not just simply going to maximum tolerated doses for drugs. We're starting to be a bit clever and think about actually what exposures will lead to biologically effective doses in patients. So we don't necessarily need to increase the dose of drug until we see those kind of maximum tolerated doses in patients, which can obviously improve the tolerability profile of the drug. So this is just an example of a number of assays that we've developed over the last few years here in Newcastle predominantly for Cancer Research UK led early phase trials, but a whole range of different drugs, so small molecules, antibody therapies, things like drugs with bicycle linkers or sort of pegylated drugs. So the drugs that come through now are a lot more interesting than the kind of basic simple molecules or small molecules that we used to get many years ago. And we do our best to kind of publish these kind of methods papers on these assays that are being developed. Just want to touch on one of those, so not really a focus on early phase development, just touching on one just to show how it can be interesting to do the pharmacology studies. It's not necessarily just a case of measuring drug in plasma. This was a drug which was a track inhibitor for this SILT defective tumors, which form these large kind of tumors on the head, on the cranium. And we were looking at quantifying a pegylated compound in tumor material. In this case, this wasn't a systemically administered drug. It was a drug that was administered topically. And assay was validated here in the pharmacology group in Newcastle ahead of the phase 1 trial starting. And then we looked at basically, in this case, it was a question of, because it was a topically administered drug, it was how deep that drug was kind of like penetrating into the tumor. So we would take these kind of like sort of plugs of tumor and section them, and then we can look at concentrations of drug in these different sections, and it gave a very nice idea of kind of how well that drug was penetrating down through the tumor and targeting those tumor cells. So an example of a kind of like a novel assay development that we've done here in Newcastle. It's a bit different than the standard measuring drug levels in plasma. So I head the Newcastle Cancer Centre Pharmacology Group. As I say, we do a certain amount of early phase clinical work, sometimes in pediatrics, but more often in adults. The work I'm going to focus on today is more relating to our kind of therapeutic drug monitoring and clinical trial work. So we do a lot of work here as a national clinical pharmacology centre, measuring drug levels in childhood cancer patients, where we either try to learn more about the drugs to help us to maybe come up with dosing regimens based on a more sound pharmacological rationale, or where we actually, for really challenging patient groups, which I'm going to go on to talk about, we actually measure patient drug levels in individual patients, and we look to adjust dose to try to get the most efficacious exposure in each individual patient. So we work with centres across the UK. We have a really good framework of centres and research nurses. So photograph on the right there is a recent research nurse training day, which was carried out in Newcastle. So we have really close contact with the research nurses who are taking the samples. Obviously, we rely on the high quality of those samples coming into the lab for analysis. So we coordinate multi-centre national and European studies, and over many years we've recruited well over 1,500 patients across 21 national treatment centres. So pretty much all of the primary treatment centres in the UK are participating in these clinical pharmacology studies. And as I say, over the years, this has developed into a national therapeutic drug monitoring service where clinicians can essentially contact us and request information on drug levels for particularly challenging groups of patients. So when I first started in Newcastle, working in childhood cancer, it quickly became obvious that when we look at pediatrics versus adults, a lot of the pediatric studies that have been done historically were done on kind of older children and teenagers, where you maybe don't see large differences in clinical pharmacology and drug disposition between teenagers and adults. Where we really see big differences, and where we've focused a lot of time, especially in the last, I would say, 5 to 10 years, is looking at trying to improve our knowledge of what we know about drug disposition in very young patients, so infants, neonates, children in the first years of life, where it's really challenging to treat these patients. And we really have very limited data in terms of what we know about those relationships between drug dosing and drug exposure. So the kind of doses that we give to these children are very much historical based, not based on a knowledge of the pharmacology. Just give you one example before I go into talking about the therapeutic drug monitoring study in more detail. I'm going to give you one example of a really nice study that was carried out over many years in Newcastle, one of the first studies that I became involved in when I started here. And this was looking at the drug 13-cis-retinoic acid, which is used in high-risk neuroblastoma. And shown on this slide are the data from a recent trial where we worked with a company in the UK called Nova Pharma. And they spent a lot of time, we had a grant from the Wellcome Trust to develop a novel formulation of 13-cis-retinoic acid, because we knew that from clinical pharmacology studies that we did here in Newcastle, we were really showing that some of these children had minimum exposure, almost certainly subtherapeutic drug exposures. And that was largely linked to challenges to the way that the drugs were administered. So high-risk neuroblastoma patients, generally very young, 0 to 5 years of age, and the only administration form of the drug that was available was capsules, and these are difficult to swallow. So we worked with this pharmaceutical company to develop a novel liquid tutti frutti flavored drug product, and this was then taken into a clinical trial, just essentially showing that we got at least as good exposure with the novel formulation as with the previous formulation. You can see on the right-hand side there those PK profiles of a crossover study where patients received on one cycle the capsules and on another cycle the oral formulation. You can see that the exposures were better with the oral formulations, as well as being much easier for the families to administer. So this was then published, and this novel formulation of 13-cis-retinoic acid is now used certainly across the UK. I think some sites in some centres in Europe have now started using this as well. But this was the kind of the end result of many years of studies. So over 20 years ago now, we did our first pilot pharmacokinetic studies. It was about the first study that I did in Newcastle. And we looked at pharmacogenetic variation to see whether these large differences were due to kind of fast metabolizers versus slow metabolizers. And nothing really kind of came out of that. We then did a therapeutic drug monitoring adaptive dosing study where we selected out those patients who had the low exposures, and we increased the dose for those patients, and that worked really well. And the data that was generated from that therapeutic drug monitoring study was published in Clinical Cancer Research, and that led then to changes to the way that this drug was used. Certainly across Europe. I haven't checked whether that's been taken on board globally. I would hope that would be the case. And then that went on to then this new drug formulation and the bioequivalence study. So we're now in a position where I think we have a much better understanding of this. We have a novel formulation which is available for patients, and I think it's a really nice example of where clinical pharmacology studies can benefit both individual patients who are having doses adjusted, but also with the long term in terms of new dosing regimens and a new drug formulation. But it just kind of flags up the kind of length of time it can take for this to happen. So this is, you know, the best part of 20 years of research that has led us to this point where, having shown we have a problem, we have lots of patients here who are potentially getting subtherapeutic drug exposures, it's taken a long time for us to get to a point where we've actually got an appropriate drug formulation that can be used in all patients. So therapeutic drug monitoring in pediatric oncology is essentially, putting it very simply, it's kind of optimizing the therapeutic use of a drug by looking to achieve what we see as a biologically effective dose, or targeting that therapeutic drug window. And this graph here shows you, if you give a standard dose of drug to a group of patients, you will almost always see some patients who have very higher exposures than the majority of the group. And these patients were concerned about toxicity, but also some patients who've got lower exposures. And for these patients, they may be the patients that sail through chemotherapy. They don't, you know, we don't see any side effects, but because they're not getting a high enough exposure of the drug, what's going to happen here is these are going to be the patients who don't respond, or they're going to be the first patients to relapse. So we for logistical reasons, we can't measure drug levels on all patients being treated with, you know, all of the drugs in the UK. So we concentrate on what we see as kind of like hard to treat or more challenging patient populations. So this includes poor prognosis patients who are receiving high dose chemotherapy. It could be infants and very young children. This is quite a lot of the patients where we do therapy drug monitoring. So patients in the first weeks and months of life. Patients who are anephric or with poor kidney or poor hepatic function. Obese or malnourished patients is a big area, certainly on the global scale, in terms of differences in drug disposition that's seen in Western populations as compared to LMIC countries. And sometimes patients receiving reduced doses due to poor tolerability. So it may be that patients who are receiving standard doses of chemotherapy just aren't able to tolerate that chemotherapy, and therefore they have to have markedly reduced doses. So looking at whether they're still achieving what may be efficacious drug exposures is important in this patient group. So in terms of the way that we do the therapeutic drug monitoring, if we have, say we're doing therapeutic drug monitoring for, I don't know, say cyclophosphamide, we would obtain the information from the center in terms of what the dose of the drug is going to be, the initial dose of drug, what the drug infusion time may be. And then we also collect information on like how often they're going to be receiving the drug, whether it's going to be given again in 2 weeks or 3 weeks. And we give them essentially a sampling sheet, a pharmacokinetic sampling sheet, which tells them at what time points to collect blood samples. And we will normally request 3 or 4 blood samples to be collected following drug administration. These will be taken and sent to the lab here in Newcastle by overnight courier on dry ice, so they maintain their integrity, they're stored frozen. And then we analyze them either by atomic absorption spectrophotometry for carboplatin and cisplatin, or by liquid chromatography mass spectrometry for other drugs. They will either be done in real time, as we do with carboplatin, or sometimes we will batch them. We will do maybe one run of vincristine a week, and the patients for that week will all be analyzed together. Data is analyzed and verified, and then the results are reported back. And then frequently, if there's a dose change required for a patient, so if we identify a patient who's getting actually very low drug exposure and we're suggesting a dose increase, they will collect samples again on the next cycle of treatment, and we will ensure that that dose increase has led to an improved hopefully efficacious exposure to that drug. So I'm going to focus a little bit on the infants and neonates, the very young cancer patients. This is a very famous figure that's taken from the New England Journal of Medicine about 20 years ago now, and it really kind of a review paper just highlighting why we would expect to see differences in drug disposition and the way that drugs are handled in infants and very young children as compared to older children. So things like ontogeny of cytochrome P450 enzymes that are involved in drug metabolism. Basic things like percentage body fat and percentage body water, which are very different in a newborn baby as compared to older child, will impact on the distribution of the drug to the different tissues and different sites. Differences in pH of the stomach, for example, and also things like your renal function. So in the first few weeks and months of life, your GFR can change quite dramatically because your kidneys are still developing. And the question that we had really when thinking about dosing neonates and infants was, okay, we give markedly reduced doses to these patients. We give mg per kg doses rather than mg per meter squared. The mg per kg dosing will have an inherent dose reduction, but we also then throw in an additional maybe 33% dose reduction or 50% dose reduction, depending on the drug and depending on the age of the child or the body weight of the child. So it's really not consistent between drugs. It's not consistent between treatment protocols. And we were interested in really kind of understanding why do we need to give these markedly lower doses of drugs to these very young patients? Is it because we think the drugs are going to be handled very differently in terms of the pharmacokinetics, or is it more related to the fact that these patients just aren't able to tolerate the same kind of exposures and therefore we need to give lower doses? And that's something that unless you generate clinical pharmacology data, it's not something that you're going to be able to answer. So it's something that over the last 5 to 10 years, we've spent a lot of time really trying to collect data on obviously what is a relatively small patient population. So the therapeutic drug monitoring clinical trial officially started 5 years ago in Newcastle. It's something that we've been doing for a number of years, but not formally. So the therapeutic drug monitoring official trial allows us to actually collect and collate all of the clinical information from the patients that we study. It's sponsored here by the Newcastle Trust, and it's funded by Cancer Research UK and the ECMC. Previous funding has been from the NIHR Research for Patient Benefit Programme and a charity called Little Princess Trust. So it's now open in, this is increased, actually I should have updated this slide, so it's now open in 18 of the 21 primary UK centres. And it's really allowed us to establish a therapy drug monitoring service at a national level. So basically at all of these centres, if a clinician has a really challenging patient, so maybe a heavily obese patient, maybe a patient with no kidneys, maybe a 2-day-old child, they can collect some blood samples and send them to us, and we will generate clinical pharmacology data on exposure in that child. And that information can then be used to help inform the dosing decisions that are made. So over 225 patients studied over the past 3 years, I think in total now. So I say we're 5 years into the trial. I think we're up to about patient 300 and close to 350. So a large number of patients in these hard to treat groups. Around 2/3, just under 2/3 of these patients are the infants and neonates. We've analyzed drug levels of 12 different drugs. We're developing assays for a couple more new drugs at the moment, which potentially are going to be used more frequently in childhood cancer. These are commonly done over multiple cycles. So we will measure drug levels over multiple cycles. And also, if a patient is receiving, 2, 3, 4 drugs, we will commonly also measure multiple drugs in the same samples for these children. Carboplatin is pretty much our gold standard because we have very clear evidence that targeting AUC is important for carboplatin. But we're starting to generate good evidence, I think, for the benefits of this approach for an increased number of drugs used in pediatric oncology. And obviously, because we're not getting lots of new drugs through in childhood cancer, it means that we're not constantly having to develop new assays all the time as we would be in the adult field, I guess. So the highest tumor types in terms of the patients who are recruited tend to be neuroblastoma, retinoblastoma, and Wilms, but this is largely down to the drugs that are given. So carboplatin and vincristine are our 2 most common drugs, but this figure is really just to show that this is potentially beneficial across all tumor types. It's not 1 or 2 different tumor types. It's more related to the drugs that are being used. So just an example of how we do therapy drug monitoring for carboplatin. As I say, this is very much our gold standard. So patients will either receive carboplatin on a single day of treatment or over 3 days. I would say 95% of patients now receive carboplatin over 3 days. And I think largely this has been a shift in the UK to this because centres like to do the therapeutic drug monitoring approach. So if we do carboplatin dosing over 3 days of treatment, it allows us to do therapeutic drug monitoring in real time. So basically we can measure drug levels, on day one, and we can then analyze those samples on day two, and then we can kind of feedback to do a dose change on day three, and it's the cumulative exposure that kind of works in these patients. So samples are collected mid-infusion, at the end of infusion, and normally 1 to 2 hours after the end of infusion. They'll be then immediately shipped to Newcastle on dry ice, and we'll receive them sort of pre-9 a.m. delivery, and we'll have our samples analysed and the results reported back normally by around 12 o'clock. And then that allows a dose change to be made for day three. So we can pretty much ensure that all of the patients in the UK who are going through the TDM program are hitting their target AUC. If there are patients who are receiving carboplatin as a single day treatment, this will normally be patients who are receiving the drug as a single day, but will be receiving multiple courses of treatment, so maybe sort of 6 to 9 courses or cycles of treatment. The way we then do the monitoring is that they give on cycle one, and they will give a dose, and we will measure the AUC, and say the AUC was 20% below where they wanted to be, then we will suggest the 20% increase for the following cycle. So they increase the dose or decrease the dose between cycles based on the results of the measurement of drug levels in the samples from the patients. So we published a number of publications and a number of national treatment recommendations for various tumor types involving carboplatin, because it's really been shown that therapeutic drug monitoring is really beneficial in these patients, and in particularly in infants and neonates. And this figure here on the left-hand side really kind of shows you why this is so important. So this is the clearance of carboplatin, clearance of the drug, so how quickly the drug is removed from the body, in 2 patients, one shown in blue and one shown in red. And this is 3 courses of treatment, and these are both neonate patients. So these courses of treatment are, first one is at 2 weeks of life, second one is at 4 weeks of life, and the third one is at 6 weeks of life. And you can see you've got this marked increase here for the patient in blue in clearance between cycle 1 or course 1 and course 3. And again, for the patient shown in red, you've got more than a doubling of the clearance of the drug in the space of kind of like, this 4 weeks between the 2 treatments. So if you're just dosing mg per kg, you're going to have a small percentage increase between course 1 and course 3. But actually, because the clearance changes so much, you actually need to approximately double the dose of drug between cycle 1 and cycle 3 in order to get the right exposure in these patients. And this is largely, it's anticipated that this is because of the rapid advancement and development of the kidneys in these very young patients. So a 6-week-old baby is much more capable of clearing the drug more efficiently through the kidneys than that same baby at the age of 2 weeks. And we've actually just published in retinoblastoma now, published I think last month in the British Journal of Cancer, a really nice paper showing the benefits of this approach to treatment in infant and neonate retinoblastoma patients. So just the other thing that we can do now, because we've started to collate data on meaningful numbers of patients, so particularly with carboplatin, where we do, every week we will do 2 or 3 carboplatin patients. This is a really heavily used national service. So we can start to pull together the data to try to generate clinical pharmacology data, which will allow us to provide more rational dosing guidelines than simply kind of mg per kg doses based on kind of historical perspectives. So generally speaking, on the right-hand side, this table gives you an idea of some standard doses of carboplatin, which is commonly 200 mg per meter squared in retinoblastoma type protocols and neuroblastoma protocol here. And then you've got these different dose reductions for the different age groups of the younger patients. Sorry, I'll just go back up. So for children 5 to 12 kilograms in this particular protocol, there's a reduction to 6.6 mg per kg. Children less than 5 kilograms reduced to 4.4 mg per kg. And that's fairly consistent that the very young children, so either less than 6 months or less than 5 kilograms, are receiving this reduced dose of 4.4 mg per kg. So what we're able to do then is look at actually what is the kind of pharmacokinetic profile of this drug in children of different ages. So we've got data here from Total of 90 childhood cancer patients, less than or equal to 10 kilograms on 165 occasions of therapeutic drug monitoring, because these patients were studied on kind of multiple cycles or courses of treatment. The target AUC is normally 5.2. We can increase to 7.8 if the patient isn't responding and that is tolerating the drug well. So almost your if you like, your therapeutic window for these patients is an AUC of 5.2 to 7.8. And we've got these dosing regimens of 6.6 mg above 5 kilograms and 4.4 mg for the smallest patients. So we generated from carboplatin PK parameters using Bayesian modeling, and we can look at the correlations between AUC and clearance. You can see here that if we look at the relationship between clearance and body weight, it's pretty linear between the patients. So there's no difference between the patients less than 5 kilograms, the really young ones, and the older ones. It basically increases with body weight in a linear fashion. And if you look at the clearance, these are the group patients who are less than 5 kilograms and the patients 5 to 10 kilograms. The spread of clearance and the mean clearance is no significant difference between them. It's actually very, very similar. So what this means is that if we want to achieve these AUCs, the target AUC in these different patient groups, less than 5 kilograms and 5 to 10 kilograms, we should be giving a very comparable dose, which is essentially 6 milligrams per kilogram to get the same spread of data. So what actually happens in reality is, on the left-hand side of this graph is the 4.4 mg per kg per day. So this is what's actually happening. If you don't do therapeutic drug monitoring, your patients less than 5 kilograms, the vast majority of them are being underexposed. You've actually got very few patients within your target therapeutic window. Whereas your 6.6 mg per kg per day, which is your standard dose for the patients between 5 and 10 kilograms, you've got quite a high percentage within this therapeutic window. If anything, they're slightly overdosed. So what we're suggesting based on the clinical pharmacology data is this dose of 6 mg per kg for both patient groups, and that's shown here on the kind of right-hand side of each of these two groupings. So this is 6 mg per kg for the less than 5 kilograms and 6 mg per kg for the 5 to 10 kilograms. And as you see, that should lead to a high percentage of patients being within the target therapeutic window for carboplatin. So I was going to include a couple of case studies here then. Hopefully we've got time to include these. So this is a couple of examples of how this works in the real world. So this is an infant neuroblastoma patient. So it's a preterm infant born at 36 weeks with left leg immobility. And there's a retroperitoneal mass causing compression of the spinal cord. So they received standard chemotherapy and they didn't measure drug levels. They just gave the standard dose, which is a mg per kg dose. Quite likely that the patient would have been underexposed. So they didn't get a response, so their decision was made to initiate pharmacokinetic guided carboplatin treatment alongside the drug etoposide. The recommended carboplatin dose was 10 mg with a target AUC of 5.2. But when we measured the exposure to the drug on day one, they were actually only achieving an AUC of 0.9. So if they hadn't adjusted the dose, they would have achieved an AUC of 2.7, which is about 50% of where you want to be. So they were well below the kind of exposures where we're likely to see a response in the patients. So the carboplatin dose administered on days 2 and 3 was increased to 24 mg per day to achieve this target AUC. And following that dose increase, a clinical improvement was observed, and there was movement of the left leg as was observed in this patient. And then an MRI scan showed complete resolution of the spinal cord compression following the completion of the treatment with this personalized dose of carboplatin over multiple courses of treatment. And then the second one is an infant hepatoblastoma patient. This patient was treated with cisplatin. So again, a neonate born at 36 weeks with the retroperitoneal mass and elevated AFP levels. Tumor biopsy at day 9 confirmed hepatoblastoma with no extrahepatic disease. And the standard dose for this is a dose of 1.6 mg per kg. So the way this works, we don't have a very clear kind of idea of what the target therapeutic window is for cisplatin. So the way that we dealt with this patient was the standard dose of 1.6 mg per kg was given on the first cycle of treatment. And this led to a nice change in AFP levels. So the clinician was happy with the response that was being seen and it was well tolerated. So we carried out pharmacokinetic studies across multiple cycles and essentially just tried to achieve the same AUC on all of the courses that were seen on the first course, where a nice response had been seen. And you can see that very similar to carboplatin, we've got more than a twofold increase in cisplatin clearance, which resulted in lower AUC values. So basically the dose had to be increased from 1.6 mg per kg up to a dose regimen of 2.5 mg per kg in order to achieve these same exposures between courses of treatment. So again, when we published this as a nice kind of case study a few years ago. So again, a nice example of how understanding drug levels and how understanding that you need to potentially change doses quite markedly in these really young patients can lead to improved clinical treatment. The other example is a drug called vincristine, which obviously, again, very widely used drug in solid tumors and in leukemia. And we've done a number of studies on vincristine. We've analyzed data. This has been published it's published in the European Journal of Cancer a few years ago now, looking at 26 neonates and infants and comparing the exposures as compared to older children. So population pharmacokinetic model was developed, and we showed that there was no significant difference in vincristine clearance, normalized for body surface area, between these very young patients and older children. And there was real inconsistency between the mg per kg doses that were given for different tumor types. And we showed that any protocol where the patients were receiving a dose of vincristine of less than 0.05 mg per kg, all of those patients were achieving very low subtherapeutic exposures as compared to higher mg per kg doses in infants and neonates, and also in an older patient population. So again, the therapeutic drug monitoring allowed us to identify groups of patients where they're being underdosed and where the dose needs to be increased. So within the therapeutic drug monitoring study, these doses would have been increased. Tolerability was fine because we're selecting out the patients with low exposures and increasing the doses so that they achieve exposures comparable to other patients. But also that this then led to a publication, which has then led to changes to dosing regimens for the infant and neonate group. And these data tied in quite nicely with a large study that was carried out by Jeff Skolnick in the US, was published in CCP around the same time. Another thing that we've done, and this is something that was worked on quite heavily during the pandemic when we had a period of time out of the lab. So we did a really detailed deep dive into looking at what pharmacokinetic data was out there for infants and neonates. So using in-house data and also published data from other groups, and really pulling together a really detailed review paper looking at what is the evidence for mg per kg dosing versus mg per meter squared dosing versus therapeutic drug monitoring approaches. So for some drugs like carboplatin, for busulfan, for methotrexate, there's a reasonable amount of data. But for other drugs, data is very sparse, and a lot more data is needed. So we published this paper in the European Journal of Cancer, and then we've also developed a website. So the website allows you to link through to the actual papers. It provides like a grade of recommendation for dosing, whether you're dosing on mg per kg or mg per meter squared, maybe some more sort of cleverer dosing nomograms like for busulfan. And the website's freely available, so I can share these slides afterwards. I can share the link. It's a really, even if you're not doing therapeutic drug monitoring, it's a really useful resource in terms of looking at what evidence is out there for a particular starting dose for these challenging patients. So just in summary then, I think clinical pharmacology can play a key role in allowing us to optimize drug use in childhood cancer. I think it's really important for the pediatric oncology community to engage with clinical pharmacology centres, and that's something that in the UK we've done, I think, really successfully over the last kind of like 5+ years. The therapeutic drug monitoring program allows us to not only directly impact on patient care in terms of optimizing the dose for individual patients, but also allows us to generate data which allows us to provide a scientific rationale for newly proposed dosing regimens. And we're increasingly developing national treatment guidelines involving therapeutic drug monitoring for a range of different tumor types. But there's still lots of work that needs to be done. If you look at, recently I've been involved in writing a review paper with the CEOP Nutrition Network group, looking at differences in drug disposition pharmacokinetics based on kind of nutritional status of patients, so in both malnourished patients and obese patients. And there's just so little data that's been published in this area. I know this is something that that Girish has been involved in India. So I think that kind of data is going to be really important, but still lots of work that needs to be done. And then just mentioning the people in my group here in Newcastle, and also collaborators who were involved in some of the slides that I showed. Happy to take any questions. Thank you.
Thank you, Dr. Gareth Bill, for providing that insights into clinical cancer pharmacology. So this session is open for question to the audience. We have a couple of questions in the chat box. So one of the questions is like, what are your guidance for dosing in obese patients?
Let me just see if I can stop sharing this, and then I can see the chat. So it's a great question, and we don't have an answer, if I'm completely honest. It's an interesting one because it's obese patients. So when we discuss this with sites, when we open the study, so we opened the study in most sites around sort of 4 or 5 years ago, we discussed the kind of groups of patients that might be appropriate for recruiting to the study. And almost all of the centres, or a high number of the centres, were kind of saying, oh, we'd really like to recruit, we really struggle with obese patients. We've got an increasing number of obese patients. We'd really like to do some drug levels. In reality, we actually haven't had that many. We certainly haven't had enough, like the data I showed you there for carboplatin and vincristine. It's where we've got enough patients to be able to actually provide, a scientific rationale for dosing regimens. We just haven't had that with obese patients. We've had, no more than a handful with any one particular drug. So it's really difficult to say. It will depend on the drug, because it will depend on whether the drug's lipophilic in nature or not. There are some patients out there, as I say, I've been working on this review paper with the CEOP nutrition group, and there are some data out there for some drugs, particularly the anthracycline drugs. But I think it's still too early to be able to say whether we should be dosing based on actual body weight or ideal body weight or whatever that should be.
So there is also a question regarding the challenges that we face in designing the PK/PD studies in pediatric populations. And do you have any suggestions regarding how we can overcome these challenges?
So it depends. There's lots of potential challenges. I think from our experience, a challenge can often be. There's a couple of things. I think with the therapy drug monitoring study, it's a little bit different because there are kind of clear advantages to patients being recruited to the study, because for that patient, we're going to be potentially optimizing their drug dose to make sure that they're not going to be overexposed or underexposed. I think that's quite an easy kind of sell to the patient or to the family. A lot of PK/PD studies that we do will be collecting information which could be used for future trials. So I think they're almost kind of requiring or relying on the altruistic nature of the families in terms of them wanting or being happy to participate in studies where their child isn't going to benefit, but it improves our knowledge of the drugs, and it may allow us to modify dosing regimens to improve the way that patients are treated in the future. It never ceases to amaze me how many families are happy to participate in research studies, based on a kind of altruistic nature of participating rather than for the benefit of their child, for the patient. But it's still a challenge. It's a hard sell, and obviously if you're requesting, if you're trying to do any kind of detailed PK/PD study, you're requesting, I don't know, multiple blood samples on multiple cycles of treatment. So even those families that do agree, they kind of want some reassurances that that it's not going to be a detrimental effect to their child in giving those samples, which are for research purposes. So I think we can do a lot now in terms of improving the assays that we use, sensitivity, so we can measure drug levels in very small blood volumes. We can do a lot with modeling to limit the number of samples that we need, so do limited sampling approaches. But I think it's still going to be a challenge doing PK/PD studies that that don't directly benefit the particular patient.
With respect to carboplatin dosing, how often are we going to get it wrong? I mean, if you don't do PK studies on a routine basis.
So I think with carboplatin, it's the patient groups that we do routinely are the infants and neonates, the very young patients, so less than a year of age, and also the high dose. So we do for some of our brain tumors, we have like regimens where you're targeting an AUC of 7 per day over 3 days, so high target AUC of 21. So there are a couple of papers in the British Journal of Cancer, one that was published in retinoblastoma very recently, and one that was published last year, which was focused more on the pharmacology. So that those papers have got some nice data in terms of giving you an idea of what the spread of AUC values will be if you're not doing the therapeutic drug monitoring, because obviously therapeutic drug monitoring is something that is a very much a gold standard in the UK, but actually is not done kind of globally or internationally. So you're going to have a fair percentage of patients who are below where you want to be. I think the ones who are above, to be honest, if they're tolerating those higher exposures, I don't think it's a problem. I think you should probably stick with it. But the patients who are below, the patients who are above who don't tolerate it, obviously will get a dose reduction anyway. So that kind of almost inherently kind of like guides your dosing based on toxicity. But hopefully you've not, caused kind of hearing loss or any kind of major organ toxicity in those children. It's the patients that are below, I think, is more worrying, because unless we're doing TDM, they're going to be, underexposed on consistently across cycles. And I'm not sure about a number, but as I say, the information will be in those papers because it has a nice spread of data. You can see the kind of percentage of patients who will be below your target therapeutic window.
Thank you. You also showed how you have developed the 13-cis-retinoic acid liquid formulation there. So, I mean, in the current context of precision medicine, there are a lot of TKIs and, sorafenib, ALK inhibitors, a lot of TKIs which cannot be scored, crushed. So it becomes so difficult to administer. And in a bit of older children, we end up giving OD doses or alternate doses instead of the recommended BD doses. So what's your take? I mean, is there any trials going on? I mean, is there any work going on where you are preparing or getting more of these liquid formulations, which will be more available to the pediatric population?
Yes. So no, that development of the 13-cis-retinoic acid formulation was it was from a specific grant that was obtained in order to do that work. It's really difficult. We're not ourselves. We don't do a lot of stuff with TKIs because we still don't. We get the odd patient through where they want to do TKI dosing in terms of TDM, but not that many. Yeah, the challenge here is who leads these things. So this company we worked with, Nova, are very that they genuinely want to kind of improve the kind of like they wanted with this project to improve the availability of this drug for children with cancer, but they're never making any money out of it in terms of a kind of like a business decision. It's not, it probably wasn't a good decision, but it's good for them to be doing something which benefits patients. With the TKIs, it may be a similar thing in terms of the numbers of younger children who are taking the TKIs, I guess. It's a question of who drives it, because it's not cheap to do. These developments are expensive.
Thank you. We have Dr. Girish also here, who has done a lot of clinical pharmacologic studies back there, and he's currently also doing PK studies here in Tata Memorial Hospital. Dr. Girish, you want to?
No, thanks, Gareth. So I just wanted to bring up a couple of points which will be useful for everybody. One is that how do you actually decide what is the required sample size for a PK study to make a kind of a conclusion that this is actually clinically relevant? I mean, would you take convenience 10, 20, 30 children, or and the second component is because it is children, we do limited sampling. How much of it will get it wrong if you do limited sampling when you're doing, say, 24 hours sampling instead of doing every?
So for the taking the second question first, it's if you've got a good model, if you've got a good population PK model, then limited sampling is absolutely fine. I think if you've not got a good population PK model, then it can be problematic. I think the key thing is just to ensure that you have a good population PK model. And I think there's a lot of work that's been done now where groups are kind of pulling together information where they've got like data sets, and we're doing this a lot with the Princess Maxima Center in the Netherlands, where but because that we have similar interests and we have PK data from patient groups with particular drugs, and they do as well, we can combine them and develop really nice models. So I think that's not so much of a problem anymore. In terms of the first question, this is it's a kind of how long is a piece of string. It's really challenging. I think if you're putting in grant applications or applications to run clinical trials, they will want some kind of power study. The way that we would do that is we would speak to the statisticians, and we would look what they would generally want. The information they would generally want would be so two things. One would be the level of variability you see in your, for example, drug clearance. Yeah. So if you take a patient population of, 20 patients or 50 patients, how many patients will you need to be able to see a difference in clearance? Because obviously, if you're not detecting a difference in drug clearance, then you're going to struggle to show anything. Yeah. So if the difference in drug clearance is large, if you've got really large inter-patient variability, you can generally do it with fewer patients. And then I guess the other thing is if you're looking at correlating, for example, the easiest thing is correlating it with toxicity. They want an idea of the kind of incidence of toxicity in patients. So again, if you're getting toxicity in a higher percentage of patients, you can generally do a study with fewer patients. If you're only seeing, say you're looking at, I don't know, sinusoidal obstructive disease, for example, yeah, VOD, SOS, or whatever it's called now, if you're only seeing it in maybe like 5% of patients, then clearly you're going to need to do a study with probably at least 100 patients in order to get enough patients within that treatment group where you're seeing the toxicity. So it's not an exact science. We will get an input from a statistician for a grant application, but how meaningful that is, I'm not 100% sure.
So Gareth, another point is that it is easy from pharmacology studies to correlate with toxicity, but far more difficult to correlate the impact of pharmacology studies on long-term outcomes or efficacy, because it's such a multifactorial thing. So how do you address that? I mean, you must be facing questions that, is it really necessary? Like Manath has put one of the questions, how many times do we get it wrong by not doing it? So how do you address that?
So that's the really challenging question. So I think the paper that we've just published in the British Journal of Cancer looking at retinoblastoma is quite a nice example of how we've got clinical data which, as compared to kind of historical data and other groups' data, it seems like the tolerability is very good because we've been using therapeutic drug monitoring for a long time. In terms of black and white metrics for showing the real benefit of this, it's really difficult to do, Girish, because it's in an ideal world, you want to do a randomized trial, where you basically have 50% of the patients get standard dosing and 50% of patients get therapeutic drug monitoring, and then you hopefully show a nice 10-15% difference in improved incidence of toxicity or improved efficacy. It's just by the time you have the evidence that, or some indication that TDM is beneficial, you're never going to be able to run a randomized study because clinicians won't want to put their child on an arm. So in the UK, because we have the therapeutic drug monitoring service, if we put together a randomized trial to look at the benefits of TDM, nobody would be recruited to it, and all the centers would basically say, can you do some drug levels for me, and we'll choose our own dose. So I think in the history of therapeutic drug monitoring in cancer overall, I think there's been 3 or 4 randomized trials ever conducted for this very, very, very good reason. I think it's just really difficult to do ethically, I think. So there's many years ago, there was a nice study published from Bill Evans on methotrexate. There's 5FU, maybe 2 5FU studies, but they're just really challenging to do. And in terms of the metrics, I think toxicity, particularly if you've got a toxicity that's directly linked to a particular drug, like vincristine-induced peripheral neuropathy, then it's nice. You can do a nice study, because it's going to be it's going to be the exposure to vincristine, which is going to be linked to it. But it's really hard. It's really difficult when you've got even overlapping toxicities. But response data is really difficult because it's rare if you ever have a patient that's just treated with one drug. They will always be treated with 3 or 4 drugs. So if we do therapeutic drug monitoring with 1 drug or even 2 of those drugs, it doesn't mean that you can then correlate it to long-term outcome, because obviously there's so many factors I think it's really difficult.
Good, thanks. Badra, you can go ahead.
I think that was an interesting session, and I think, as we already pointed out, something which is increasingly being discussed, and something we usually don't commonly discuss also on common forums. So, thank you so much for joining us today, taking your time out. Thank you everyone for joining. Thanks so much, Dr. Gareth. I think we'll take leave.
Just one small announcement, Badira, that for
Yeah.
next 2 months, we are not going to have any national or international webinars because we have SEOP, we have FOCON, and we also have ISMPOCon. So a lot of meetings in the next 2 months, and then we'll resume our academic program in the month of December. Thank you for that. And thank you, Dr. Gareth, for taking time out. And
Thank you. I'll be at the SEOP meeting, so if people are there, it'd be good to have a chat.
Thank you so much for being here.
Yeah.
No problem. Thanks very much.
Thanks a lot. Thanks, Gareth.
Take care.